So the next part is on the therapeutic fundamentals, again on the Hematology Oncology Fellowship. And we're going to have Dr. Kebede Begna. He is a hematologist oncologist and associate professor at Mayo Clinic. So, and then of course, one of the major players in the effort to build this fellowship.
Thank you, Dr. Antone. Really, I want to talk to all the presenters and also to my colleague from Mayo Clinic, Dr. Dong Chen. So to start with, really, this may apply to every medical institution. The core value, whenever you have a patient, you need to learn or educate others and learn about the disease. And there has to be some kind of practice and research. We have been talking earlier about registry and so on and so forth. Really, most of the information that we are talking starts from the patient, from one patient to many patients. These are the three major science centers at Mayo Clinic. We have the Mother Center, Rochester, Minnesota, more than 150 years, and Jacksonville, Scottsdale, and also there are a lot of network sites. These are the contents of my talk. I'm going to concentrate about therapeutic advances and why we need a hematology oncology fellowship in our country. Cancer starts from our own stem cells. Each and every organ has stem cells, and those stem cells have the characteristics of self-renewal and programmed cell days and differentiation. In cancer, we lose the third arm. They lose the power for differentiation. So what are the epidemiology of deaths in Ethiopia? HIV, this is a long, maybe 10 years ago. But when we are talking about, for example, HIV AIDS, most of them, they don't die just only because of HIV. They may die of CNS lymphoma, cervical cancer, and other cancers. So those are not reported as if they are dying of death. So if you see the cause of death, I believe it is only the tip of the iceberg. I don't think a lot of patients, for example, a person who's dying of car accident, he might have undiagnosed breast cancer, undiagnosed colon cancer. So we can't just say the cause of deaths are only this one. The incidence of cancer is very high in developed countries because most of the life expectancy of most people are higher in developed countries, and cancer is really much more common in older individuals. But a little bit to say, you see, unfortunately, when you say older individuals, when do you say old? Is it more than age 50, more than age 60, 70? It is really a moving target. From time to time, people tend to use, when the life expectancy of people increases, the definition of old age also changes. This, for most of the cancers, really happens at the peak age between the age of 40 and 60. And it takes really the people who has a lot of experience in every kind of, for example, physicians, when they are in their 40s and 50s, really they have much more experience, and these are taking the cream of the population. And the death is significantly higher in developing countries. Most people have shown that. I will say cancer maybe is killing Africa, because when people are dying of cancer, it takes the people who may be able to teach, modify, mentor the next generation. I think Dr. Saladin and others mentioned this. 1 in 6 days is usually due to cancer, about 1,000 deaths per hour. If we know that 1,000 deaths are happening because of cancer, everybody may be jumping up and down. And it says cancer is a disease of the developed world, but I think it is a myth. We have seen on different epidemiological data that yes, cancer is increasing in developing countries, and unfortunately, most of the burden lies in those resource malaligned countries. I want to use the word again and again, resource malaligned, not resource constrained. Our resources are going to different things rather than taking care of our patients and our maybe giving clean water. So the incidence is going to increase significantly in the coming decade or so, because people tend to live longer. When I leave the United States about 25 years ago, I believe the life expectancy of Ethiopians was around 43 years. Now it is about 60 years. So the incidence of cancer is going to increase, especially in Africa. And at the same time, the death rate is not going to increase in Africa. So we have to act to decrease this trend. Available resources this morning have mentioned that there are significant lack of resources. As you see here on the data, the screening for cervical cancer, because of different reasons, is not available. The screening for colorectal cancer is very low. I don't think we do colonoscopy. So when I am talking about the treatment, I will try to mention a little bit about also prevention and screening. One of the problem is lack of physicians or trained manpower. Yes, we have some tendencies that there are doctors who are trained here, but they don't have the work available, but that is because of the lack of infrastructure. So if you see, Ethiopia is one of the lowest in physician density, even among African countries. The low-income country, 0.4 per thousand. Ethiopia is about 0.1 per thousand. This has been mentioned. Maybe the radiotherapy centers in Africa, it is significantly lower. In Ethiopia, there is maybe 1 or 2. And what we need is maybe 100 radiotherapy centers functioning. Now is, I think, 2. And this is also when the population was about 80 million. So the question is, what should we do? How can we do despite all the limitations? How can we improve diagnostic, therapeutics, and human power? As you know, those kind of cancer care and control could happen in terms of diagnosis, prevention, and treatment. Really, in terms of diagnosis, I really believe, I'm sure the hematopathologist here, Dr. Lucky, will agree with me. We may not need to have significant jump. I usually use the analogy of this dialing phone to cellular phone. Most of you have iPhone, maybe better than the one I have. But 20 years ago, even I don't think there was a possibility to have any kind of phone in the house. So I believe the diagnostic changes that we may be able to have will improve or narrow the gap we have from developing countries to developed countries. To give you one example, for example, the diagnosis of CML, one of the diagnosis which was maybe diagnosed with a simple blood cell without doing a bone marrow biopsy, without doing the cytogenetic, just identifying a BCR level fusion gene by doing a PCR test or a FISH test, you are able to treat the diagnosis. Actually, some years ago, when Ethiopia was not able to get the tyrosine kinase inhibitor, which is approved for this disease, WHO was demanding them to make a diagnosis to give them the drug free. So they were sending the sample to South Africa, but I think now they are able to do or make the diagnosis using a different kind of genetic test. So I believe the molecular test hopefully will narrow the diagnostic gap we have. Prevention, really, it's also one of the important modalities in cancer treatment. Actually, the old saying is prevention is better than cure. So there are a number of vaccinations or screening modalities that we are able to use, but I was really disappointed where Professor Senait says that there is a papillomavirus variant which are not covered with available vaccines. Really, I don't need to tell you, really the main problem is mal-aligning of all our resources we have, unfortunately, because of different circumstances. So only by avoiding poverty, most of the cancers may be also eliminated or decreased. For example, hepatitis B, hepatitis C, papillomavirus, all can cause a significant amount of cancer. All these are preventable by rightly aligning the resources we have. Prevention, Fortunately, I believe through advocacy, the Ethiopian governments, the parliaments, they have passed some kind of rule to decrease the exposure or the incidence of smoking. So I will concentrate more on the treatment aspect. Really, in the last 50 years, half a century, significant progress has been done from no therapy to almost curing some of the, actually I can say most of the cancers. If not cure, you may be able to prolong the life expectancy of individuals. So these are really the traditional way of treating cancer, surgery, radiation, and chemotherapy. Still, we are using it, but really we are moving away slowly from this modality of treatment to more of targeted therapy. In the next 5 or 6 slides, I will show you that the different progress that we had in the last 1 or 2 decades. So really by using the different modalities of treatment, we haven't significantly increased the life expectancy of patients with different cancers. So chemotherapy kills by killing both good cells and bad cells. Sometimes treating with chemotherapy lead to a different kind of cancer. Usually I use, I don't know, some of you, especially from the West, know her, a Good Morning America commentator. She was diagnosed first with breast cancer, then she gets chemotherapy, then she gets another kind of disorder or leukemia, MDS, and she has to undergo stem cell transplant. And she looks like a person who has never had any kind of cancer. So things are moving anyway. So still chemotherapy is one of the modalities of treatment, but it is not the best. I'm using this example because first we should know the pathogenesis of the disease. Really, the CML is a prototype of any kind of cancer. Really, before 1960, there was a lot of theories how a cancer is happened. So the discovery of Philadelphia chromosome, then in 1982, the fusion gene BCR rebel, and after 20 years, Gleevec really changed the way we treat every kind of cancer. So these days, a lot of people speak about individualized or targeted therapy. I really talked about individual targeted therapy in 2019 here. We would come on the World Cancer Day. It was celebrated on February 4. And this was, I spoke about this kind of treatment 4 years ago. And we try to really establish hematology oncology fellowships with other institutions. Every time there is ups and downs, hopefully, finally, it may be coming to fruition. So the different kinds of really advances happen because of these 5 or 6 categories: tyrosine kinase inhibitors, immunotherapy, monoclonal antibodies, cellular and genetic therapy, and AI, I believe, may be helping us in making this labor-intensive diagnosis and also choosing a therapy, because there could be similarities among, for example, there is IDH. Those who went to medical school know in Krebs cycle, IDH mutation is described in cholangiocarcinoma, in glioblastoma, leukemia. So there may be some kind of medication which may be targeting the same. So artificial intelligence might help us the genetic abnormalities which may spawn different cancers. So only in the last really 20 years, more than 100 tyrosine kinase inhibitors to each and every kind of disease is described. And immunotherapy really advances more than a century. This was in New York City, where they use to treat some kind of cancer with a germ which is known to cause erysipelas. So immunotherapy is helpful because you may be able to identify the normally when cancer developed in our system, it should be eliminated by the regulatory cells. We call them T cells. Those T cells are somewhat confused by the cancer cell because the cancer cell looks like that of a normal cell. And by immunotherapy, we may give some kind of medication which may pull the T cells to the cancer cell, telling them that this is the enemy and destroy it. I am really using a very simple analogy. The molecular markers and the process is a little bit complicated for this talk. So the monoclonal antibodies, really, as I said, the cancer cells and the normal stem cell different surface antigens. For example, when we say about flow cytometry, the flow cytometry will identify those markers on the surface of cells. And there are pretty much every kind of antibody directed to pretty much all known surface antigens on the cancer cells. And some of them may be on the clinical trial, but I think every kind of disease has antibodies directed to the cancer cells. Most of them are approved and for the last 2 decades or so. Really, the other impressive thing is, in addition to using immunotherapy, is cellular therapy. In case of cellular therapy, it is somewhat similar to that of allogeneic stem cell transplant, meaning in allogeneic stem cell transplant, you take somebody's stem cells and you give a lot of chemotherapy, chemotherapy to deplete all of the cells, all of the dividing cells the person has, and you give them somebody's stem cells. That is a little bit, has a lot of complications. The outcome hasn't changed in the last 2 or 3 decades. So cellular therapy really changes the way we think about cancers. In case of cellular therapy, take out the T cells, which you arm them with different antigens. They were able to identify the cancer cells. So in other words, you take out the T cells, you arm them, and you put them back. So it is similar to that of autologous stem cell transplant. The toxicity is much tolerable, and the outcome is really very impressive. And this was first done in hematological malignancy. As you see, allogeneic stem cell transplant, the 5-year survival is less than 10%. But with this kind of treatment, the 5-year survival is 90%. It's almost curing a disease. And these days, CAR T-cell is not only to hematological malignancy, it is applying to every kind of cancer, including solid tumors. And the other important thing may be allogeneic CAR T-cell. When I say CAR T-cell, the one we have now is you have to have some wait time. You have to find lymphocytes or T-cells from the person, take them out, arm them, and put them back. So this requires a lot of time, sometimes up to 2 or 3 weeks, sometimes 4 weeks. During this time, the patient could die. So there is a trend to use allogeneic CAR T-cell from anyone who is donating blood. Take out the seed cells, arm them, and give them to patients with cancer. The other important is gene therapy. TP53, as you know, it is found on chromosome 17, and they say it is a guardian of cancer. It is a tumor suppressor gene. In any kind of cancer who has mutation on TP53, the outcome is really dismal in either liquid or solid tumors. So there is a CRISPR technology, which I mentioned in the patient with hemophilia. They, in this case, they take out the abnormal mutation, replace it with the normal gene, and supplement it to produce a normal amount of enzyme. So we are going from surgery and or chemotherapy to targeted therapy, and really the lifespan or the tendency for people with deadly disease could be prolonged or improved. As I said before, the technological know-how we have still is not coming to medicine or cancer. We hope with the availability of really collaboration, maybe collaboration with others, we may have a jump from that of chemotherapy to the latest trends in the treatment. All this will be possible if we have the diagnostic capacity. So I want to emphasize really without diagnosis, especially a hematologist and oncologist, they can't do anything. So what do you need? Investment on infrastructure, investment on human capital, and really the enemy is free stuff. Free stuff, I don't really, we have been helped by the West for the last so many years, we couldn't improve ourselves. So free stuff, yes, they may give you a startup, but we have to be innovative to avoid just free stuff and invest in our infrastructure and also human capital. Really, I'm sure there is someone from the Ministry of Health and others. When we meet our minister in the coming days, really I am forwarding to have a Ethiopian Cancer Center and Fellowship Program Endowment Fund. Instead of waiting for others to come and give us money, there are a lot of people who want to take their families to other places for in search of good care. Those individuals, I'm sure they may spend 10 times more, let alone the emotional problem they face when they go to another country. Here, there are the big people. There are nobody. I think they know it. We have to have some kind of collaboration as we embark on establishing hematology and oncology fellowship, because that requires a lot of investment. That investment, if we are waiting grant or some kind of aid from the West, it could not be materialized. I think we have to take such kind of initiative. Thank you.
Thank you, Dr. Kebede. Yeah, always speaks about self-reliance every opportunity he gets, because we all know the conventional paradigm has not worked. So that's why we're trying to have indigenous solutions for our problems, and then having involvement and a triangular partnership. And it's also encouraging that, although cancer remains a big killer, there are a lot of things coming on the horizon with precision medicine, from toxic treatment to more targeted treatment. So that's why it's exciting to start this kind of program at this time.